Brian Cheeseborough, and then John Lee, and then Jeff Glass are going to present, and then we'll open it up for discussion. So with that, I will hand it over to Brian.
Thanks. It's nice to be here. I feel like I should have had a bicycling picture sent in. I should have done that. But I don't look as good as in Lycra as John and Jeff do. Thanks for the invitation to be here. I feel like I know most of you, but for those of you who don't know me, I'm an anesthesiologist in Portland. I've had the pleasure of working with Beth and Jeff for several years in Providence. And clinically now I've transitioned to work at Oregon Health Science University in the Portland VA. So I'm here to kind of set context and start so that we all start the conversation later from the same spot. And really, as Gwen mentioned, we're here to really focus on nitrous oxide deactivation, but I think it's worth kind of taking one step back to see where nitrous sits in the context of medical gas-related emissions. Next slide, please. So medical gases that we're all familiar with, it's kind of anesthesia 101. The main point that I wanted to raise in this slide is that while the potent general anesthetic gases are really used for general anesthesia, nitrous has several uses. It's an adjunct to anesthesia. It's never really the workhorse of an inhaled anesthetic strategy, but it's also used for analgesia, sedation, and cryoablation. So it's not just, I kind of resist the temptation of lumping nitrous and calling it an anesthesia gas because it's used more broadly in healthcare than just anesthesia. Next slide, please. These medical gases can contribute up to 40% of a hospital's direct scope 1 emissions. Here in this figure, every bar is an individual Providence hospital, indicating the percentage of scope 1, primary scope 1 gases or emissions for each hospital. And you can see there's a lot of variability from the one at the top, which is about 40%, to the one at the bottom, which is less than 1%. And it drives home the point of it's really important to do the assessment and figure out what your biggest opportunity is. Next slide. Mitigation strategies for each of these classes varies. For volatile anesthetics or those potent general anesthetics, really it's a clinical decision. Clinical management determines the emissions. So the primary stakeholders are the people who you're asking to change, whose behavior you're trying to change. Those are clinicians. And some might say that's more difficult to get a clinician to, change their practice. I don't know. It depends on how motivating you are. But really the operational lever that you have to mitigate is really grounded in clinical quality improvement. Whereas with nitrous oxide, as we're all familiar, it's the integrity of the facility's infrastructure that determines the emissions. In this case, the primary stakeholders who you're asking to change are not clinicians. You're asking your facilities teams to change. And we can talk about that later. But I think it's important at the onset to figure out who's going to resist you, who's going to have to change. That's probably where your biggest resistance is going to come from. So it's worth preparing yourself for those conversations. The mitigation action is process and system reengineering for nitrous. Next slide. As we all know, central nitrous supply systems are notoriously inefficient. This is from a paper that we published last month. It's a combination of hospitals from the Providence Health System and UCSF. The point here is all the blue those are the wasted liters of nitrous per year at each hospital. And we separated them into large, medium, and small hospitals to drive home the point that it's not just a large hospital problem, it's an all hospital problem. But all that blue is mitigation opportunity. Next slide. We quantified this at a hospital here in Portland. The central system on the left, the portable system in the same hospital on the right. The divergence of the lines on the figure on the left shows you just how wasteful the central supply system is over a period of 6 weeks. Whereas on the figure on the right, the lines are hugging each other, and that's a sign of efficiency. All told, transitioning to a portable supply system can reduce consumption by over 90%. We've seen that over and over again. So the opportunity is there, and it's not that hard. There's two operational phases to the project. One is that you need to do first is establish a reliable, safe, effective, portable nitrous supply system. And then once that's in place and you trial it, then you work toward deactivating the central supply system. Next. There are a lot of benefits to this, and there are a lot of issues to consider. All of these facets of quality and cost need to be considered when you're thinking about any kind of decarbonization project, in my opinion. Compliance really comes to bear in this project when you talk about operationalizing this change. Next slide. And really, it comes down to making sure that the portable system that you implement is compliant with NFPA 99, which is the kind of code, healthcare facilities code document that so many of us use. Making sure that the management of portable cylinders is compliant with that code, as well as the deactivation of the central supply system is consistent with the code. NFPA 99, what it does do is it provides rules and regulations guiding the storage, handling, and use of portable cylinders, and as well as the design, use, and maintenance of central supply systems. That's what it does. That's what it says. What it does not provide specific guidance on deactivating a central supply system. And I think that's a really important point. What we did in Providence, and John and Jeff will talk about this a bit more, and we can talk about it in discussion. It's using NFPA 99 code to inform the proposal of your action plan to deactivate and to transition to portable cylinders. NFPA 99 does not tell you how to do it. You have to figure out how to do it, and you have to figure out how to do it and maintain compliance with NFPA 99. It's not that hard to do, but it requires your work to develop your own plan and your own proposal. You're gonna see these links over and over again. There are resources that are freely available to help you. John's going to talk about the one on the left. Jeff may talk about the one on the right. They are similar. They complement each other. You should read both of them. You should use both of them. They kind of take different tacks on the same topic, obviously, but they're free. Go use them. Ask us questions. We're here to help you. With that, I'm going to yield the rest of my time and let John take over.
Thank you so much, Brian. And thank you again for your incredible leadership on this important topic. Next slide. So I was lucky enough to kind of resituate myself within healthcare sustainability at Virginia Mason Medical Center, which folded into Common Spirit Health a few years back. And during that move, I became active in an excellent community of my counterparts at other health systems within Oregon and Washington. And we think we were pretty successful, especially with what came to be known, what we somewhat out of fun started calling ourselves the Cascadia Nitrous Oxide Collaborative. And I want to discuss how that evolved, how it came about, what we feel like we did well. And with the next slide, I'll explain how it came about. We have always had a legacy of what we called roundtables among us sustainability leaders at Virginia Mason, at Seattle Children's, and others, especially in Washington, some in Oregon. And we would use those to help each other out, to just describe our progress on a number of different sustainability initiatives to each other so that we could learn from each other, so that we could provide motivation for each other on trying to all do great work, learning from each other's mistakes, especially. And this turned into kind of a focus on the Washington Clean Buildings Act that my friend Jeff was instrumental in helping us kind of come together and provide policy advocacy and feedback to the regulating bodies. And then once that was all done, around that time, I attended the Clean Med session back in 2022, where Brian and Andy Mason, the facility manager at St. Vincent in Portland, Oregon, talked about their findings, their analysis, and I was truly blown away with what I learned regarding the level of waste that was happening in centrally piped nitrous oxide systems. So I gathered the band together again to talk about, should we do a roundtable really focused on this one topic, or two roundtables, because I felt like it was so important of a revelation that we wanted to share with our counterparts throughout ultimately British Columbia, Washington, and Oregon. And we were just all so inspired by Providence's work that we wanted to basically get the word out to every facility, every hospital in those two states and that one province. So we set about doing so. And along the way, right before our first very large, regionally focused webinar, we had a stroke of luck in bringing an individual who was working on his MHA degree, and his name is Adam Lowe, to help me kind of co-coordinate the whole experience and to essentially measure our effectiveness with our webinar and ongoing initiatives as a collaborative. Next slide. So our first webinar took place in May of 2023. We had nearly 400 registrants, primarily from within our region, but a few of you might have joined in on that one. We had, it was scheduled for 90 minutes. The Q&A followed on, making it a total of a 2-hour experience, many of which stuck around for. We were amazed. And we got a lot of accolades for that, and a lot of ahas and I can't believe it's kind of messages from a number of different clinicians, and especially facility managers, some peri-op managers, and anybody who is interested in these kinds of sustainability topics throughout the two states and one province and beyond. Then Practice Green Health was kind enough to put the recording up on its website, and we got a fair amount of national attention on this via that mechanism. We then set out to write and edit a how-to and an explanation of the many benefits of deactivating piped nitrous oxide systems. As you just learned, it is a free, still available tool, and it's through the Practice Green Health website that you can find that. We did a follow-up webinar that was far more on kind of how's it going? What are the problems that you are experiencing? Where are there any roadblocks? And can we offer our suggestions based on our own experience for how to overcome those obstacles? We use this whole process really to help each other with performing the deactivation steps somewhat simultaneously across a number of different health systems. And what was different about this collaborative than any of the other ones that we had done in our region was that we really set out with that vision to reach every single hospital in the two states. And we were highly effective at doing so. We believe that we have reached just about every hospital with the information, and many, although I can't tell you by percentage exactly how many at this time, are somewhere along the journey or the path of performing these deactivation steps. So next slide. I wanted to just quickly share that whole experience really allowed me to use the momentum of the group to successfully perform that transition at all 10 of the Common Spirit hospitals in Washington and Oregon within a 6-month period. And here are some of the things that we did in a somewhat more quick and dirty version of deactivation. We really leveraged an SBAR document that I put together alongside my partner in crime with all of this effort within Common Spirit in our region, and that is Dr. Wynn Strokebeck. He and I authored an SBAR so that we could really reach out to as many stakeholders as possible with a quick email to give them the lowdown on what we had learned from Brian and Andy and Jeff at Providence that was going to inform what we needed to do, especially the why, but also some of the data that we had already gathered regarding what Virginia Mason had done. We found that recruiting an anesthesiology champion within each facility or hospital was a great way to start, so that as we then turned to the facilities, peri-op, and biomed leaders, they could hear not just from me, but also from their own local anesthesiology department that they were behind this full force, that they had no problem with the idea of deactivation. And that really opened up the gates, and we found that we could then help each facility with their needs assessment, their implementation responsibilities, and we would notify the COO and CMO once we were ready to pull the trigger. 3 of our 10 facilities decided to outsource the deactivation details to their MedGas certifier. The rest educated themselves and just used their own internal resources. So that's it for me. I'm going to now pass it over to Jeff.
Thanks, John. Wonderful presentation from both of you. I feel a little intimidated to follow you both, but I'm glad to provide a little bit more of the context and the story that is Providence's experience with deactivation. And let's go to the next slide to start that. I'm going to start with kind of our experience and some of our lessons learned. As you can see, this is where we are right now. 82% of our sites are disconnected. You heard Brian talk about this transition really in our approach includes 2 phases. One where we go through a phase of disconnecting the pipe system, but still keeping it pressurized. And then the second phase being actually depressurizing and moving to cylinder-based at anesthesia machines delivery. So you can see 41 out of our 50 sites that use nitrous oxide are disconnected, and 64% are depressurized. So we don't get the full benefit of the carbon emission reduction until we have fully depressurized. And I guess the other thing I would say, which goes to the second bullet, we had a couple of early adopters. St. Patrick was really our first adopter, and that at one point in time was a hospital where Beth Schenk was the sustainability manager, now about 3 years ago. And it was really her efforts that kind of lit a match like they have in so many of our initiatives in Providence, but asking questions about nitrous oxide use, exploring that with her facility staff, and kind of coming to the conclusion themselves long before Brian and I really even arrived on the scene. Hey, we seem to be wasting a lot of this stuff when we look at the purchasing records versus what we think we kind of understand about how it's used. And we came to the conclusion at St. Patrick that we were leaking it And we came to the other conclusion that we could not figure out in any way how to find the needle in the haystack to determine where that leak was. So we concluded that we did not have a solution for correcting that leak. And the final result of that was to do what now is a movement across this country, and that is deactivation and depressurization. So that was the early beginnings for Providence, probably in about 2021 or thereabouts. From that, though, we also initiated a program, which I know John has done as well, of tracking our purchase of nitrous oxide very closely. And I'll show you a couple of trends that are really telling in terms of, actually, it's these two sites, which we regard as our early adopters. The other point I would make about these two sites is they've proven the hypothesis, if you will, that Brian, now has indicated there is sufficient data to prove that most, if not many, of these systems are leaking at levels of 90+%, and that these systems could be deactivated and depressurized with a limited amount of risk and really no impact on clinical delivery, and that the anesthesiologist would still have the option of nitrous oxide and with really minimal safety risk in the transition. So in terms of our approach, and we're in the 7 states where we do business, we inquired in those that we felt would really have an interest at the state, have a more kind of regulatory reach within our states, and those were Washington, Oregon, and California. Alaska, Montana, and Texas really didn't have any real, interest, if you will, or perceived oversight for approval or regulating that. So in California and Oregon, the conversations were we do not require any formal approval process or submission. In Washington, it was a little different. They wanted to go through a approval process, and for them, this was, as many of you I think will know at other states, a completely new experience and something that they didn't fully understand. And they had initially asked us for a risk assessment and some limited supporting documentation. As we started to talk with them about this process and they learned what was involved, they come to ask for quite a bit more information and a little bit more rigorous process that we're currently working through. So point of this bullet is, of our 7 states, one of them has required a formal approval process. Here are
Jeff, I don't want to interrupt, but I just want you to know you have 2 more minutes, and I know you have more slides.
Yeah. Okay.
Thank you.
So I'll then just leave the 4th bullet for you to read. Brian did a nice job of laying that out. We did find that in probably less than 5% of our sites, we did need to make some investment in modifying our anesthesia equipment for cylinder holding brackets. Learning the hard way a couple of times was modifying pressure alarm panels is an important consideration. We've actually run into a couple instances where we have old enough equipment that it's forced us to have to replace those alarm panels. Not inexpensive, but in no case was it ever a impediment to getting the work done. And then the point John made, facilities, clinical services, anesthesiology, respiratory therapy for purchasing. It's a really important collaborative, and sometimes this kind of forges relationships where there hasn't been a lot of coordination or communication, which sometimes can be an issue to overcome. And then again, the link to our toolkit is there on the final bullet. So I just was going to share with you a couple of actual trends and graphs. This first one was the one I mentioned at St. Patrick. I guess I did say that was 2021. What you're seeing there with that ski slope downward graph is actually a rolling 12-month reduction. So we made the hard reduction early 2020, and then rode our way down through the year to get to that target, which we're measuring emissions in metric tons per OR as our benchmark. And then you can see we've created this graph that gives us key KPIs. In this case, over this period of time, 2020 to 2024, we've seen almost 500 metric tons of carbon emission reduction in St. Patrick, which is about a 300-bed community hospital, 92.5%. Did the math on pounds, over 1 million pounds of carbon emission. The second example at St. Vincent is on the next slide. Similar story, not maybe quite as dramatic, but you can see that we've dropped that down to, I think we're sitting right about 2 or 2.5 metric tons per OR as our benchmark, and are having reduced 85%, or almost 2 million pounds of carbon emissions reduced since inception.
Can I make one point about that, Jeff?
Yeah.
So the reason St. V's is not as low as St. Pat's is that the remaining nitrous being consumed at St. V's is through those other clinical services. So when we started, over 90% of nitrous consumed was via this central supply system, and cryoablation and analgesia sedation use outside the OR represented 12%. And now that 12% is what we're left with, right? Because we've dealt with the central supply system. It drives home the point, for me at least, that it's not, this is the biggest piece of the pie, but it's not the whole pie, right? So there are other clinical uses of nitrous beyond the central supply system. But by far, deactivating your central system is the most juice you can squeeze out of this project.
That's great. Thank you. Oh, sorry. Go ahead, Jeff.
I was just going to say that brings us to the end of my slides.
Perfect. Thank you very much. Thank you, Brian. Thank you, John. Thank you, Jeff. It was very informative. We're now going to spend the bulk of our time in conversation. I see some questions already popping up in the chat. Katie, do you want to share yours, or shall I read it?
I can share mine. This is a question for Jeff, or really, or others. But when reading the Providence playbook or toolkit, there is a portion for the depressurization trial. I am wondering, is there any regulatory risks or pieces that are important thinking about using that trial period as a way to stop the leaking while working through this, like the regulatory requirements for a specific state? So for example, if Washington is requiring a lot more steps and things like that, are you still depressurized or depressurizing in the meantime while you're working through those steps? And are there any risks that your hospital is taking on from a regulatory perspective for doing that?
Is there anybody from Washington DOH or Joint Commission on the call? Just kidding. This is for all of us. So in Washington, we have had a couple of sites that have inadvertently jumped ahead, not realizing the process. And we've, as I mentioned, seen the process change on us pretty dramatically in midstream from DOH. So I'm being transparent here. We have a couple of sites that have depressurized, but it's our intention not to depressurize until we have received the approval of DOH. So I think that is a conversation to have with your state Department of Health, if this is something that they want to see their approval, formal written approval. For in our case, it hasn't really been explicit. What our Department of Health has said is basically, proceed at your own risk, so to speak. So I guess that's how I would describe that, if that's helpful, Katie.
Yeah, thank you.
And the one side is to consider the regulatory piece. The other is kind of the practical piece, and how, like, every step you take, can you walk it back if something happens? Obviously, the disconnection trial is really easy to walk back. You just plug your machines back in. The depressurization piece is more involved if you want to walk that back, but it's still possible. If you maintain the integrity of the central supply system and you don't remove anything, you just depressurize it. There is a process that's described in NFPA 99 about priming a new system and getting it ready for use. There's testing that you need to do, and there's protocols that you would need to follow to kind of reprime your nitrous system for subsequent use. It's a little bit harder to walk back. Obviously, the deactivation where you're removing components, that's pretty committing. So I think if you were to spell that out to the regulatory agency, they should let you. I mean, if I were a regulator, I would let you go through and say, okay, yeah, even I put my most conservative hat on, I would let you go to depressurize and then say, okay, let's work through the final truly committing step together.
Okay, great. Let's go to Cecilia.
Hey there. So we are in the process at Advocate of trying to stand this project up, right? It's going in front of our Anesthesia Governance Council at this moment. We have a super committed anesthesiologist who's helping kind of be the clinical leader. And yeah, we're working through some of the challenges of like who is gonna, like PDC doesn't have a lot of capacity to do all this decommissioning. My question was really around something I've discussed with a couple other people around this NFPA piece. I thought I understood. So NFPA 99 doesn't make reference to this decommissioning, but I thought maybe there was an updated version of that does, or maybe I had looked at some of the comments. I saw Dave Thompson from Providence had put in a comment for NFPA 2024 updates around this issue specifically. So I wondered a little bit, I think it sounds like a complicated process to jump through that hoop around NFPA 99. My understanding is that some states had, like, that there was a newer version that CMS could refer to, but had not done that in some states. And so I guess one question after sitting yesterday with Liz Fowler at this National Academies of Medicine meeting is there an opportunity for us to go to Liz Fowler and CMS and ask them to look at this as a barrier to moving forward on this work? Because I do think she's actively trying to look at what those barriers are, and I think it would be an opportunity, but I want to make sure I really understand what's happening there.
Sure. So NFPA 99, so CMS kind of mandates that hospitals adhere to NFPA 99 version, I think 2012 or 2018, an older one, right? And there's no mention of any sort of deactivating the central supply system in that version.
Mm-hmm.
In 2024, there's an appendix that makes reference to it, but the appendix doesn't count as part of the code. It's like supplemental information. They don't consider that formally as part of the code. So even as that comment, that phrase exists in 2024, it's not considered part of the code because it's in the supplemental appendix. Mm-hmm. So they're going to CMS and trying to get them to adopt 24 still won't accomplish what you're trying to accomplish, because NFPA needs to take that appendix and put it in the code because it's not there right now. It's helpful that they put some language around it and they talk about it a little bit, but it's still not part of their formal recommendation. So
that is super duper helpful, Brian, because I mean, the other thing is in this policy financing and metrics work group of NAM, they're asking us to raise what are those policy issues that could be addressed by some of these different agencies. And so I think that, yeah, in addition to my other conversations, that helps me better understand where the problem is. So we would need NFPA to integrate that appendix that makes reference.
So the regulatory steps that you would need would be first you go to NFPA 99, get them to pull that appendix into the code and draft a section. How do you deactivate a central system? That'd be super helpful. That doesn't exist anywhere. I would love for them to do that. And then once that's in the next version of NFPA 99, then you would go to CMS and ask for a waiver and say, can you allow people to use this section of 24 and adhere to that? But if you jump straight now, it won't accomplish what you want it to accomplish. Again, you need to look at the code and say, well, what does the code say about how the central system is supposed to be used? And then kind of in your proposal, kind of re-engineer it back and say, okay, I'm going to label it the same way. I'm going to label it the way I would label a functional system, but I'm going to label it as dysfunctional or deactivated. That's how we applied NFPA 99 code language to develop our plan and our proposal to deactivate. Does that make sense?
Yeah, super duper helpful. Thank you.
And I would just add to what Brian said. I agree with everything he said, but to me, I think of it a little bit simpler terms. NFPA 99 is mostly a construction code. In fact, it's almost completely a construction code and a design code. These appendixes are the one point of the code that they talk about operations, and they're not adopted as requirements, as he said. So we're really kind of mixing our codes here. We're talking about an operational process of deactivating a pipe system and trying to fit it into a round peg that is a construction code, NFPA 99. And the piece of 99 that speaks to this is in new construction. And a large part of what Dave was working on doing was actually taking out the requirement for new pipe nitrous systems in any requirements like the FGI or 99.
Yeah.
So, yeah.
Super helpful.
That's very helpful clarification. Lucy's been waiting patiently, so I'm going to hand it over to Lucy for a question.
Thanks so much. So I'm Lucy Everett. I'm an anesthesiologist at Mass General here at Jonathan Slutzman's invitation, and we have relied heavily on Brian's leadership for our work in the area as well. And we're just having in the middle of our, we're to the point of all of our ORs are on the nitrous tanks, and we're getting ready to take the next step with building and ground. So this has been incredibly helpful. I did want to back up a little bit and say that both Brian and I have done a little work with Epic, and Epic for sites that are on it has actually now implemented an anesthesia sustainability dashboard based on some work that we had done at Mass General. And you can use it to sort of track progress and usage and do things like really quickly calculate how many nitrous oxide cylinders each of your operating rooms uses per month, so that you kind of we use that in our planning to say, well, okay, how many more cylinders than we currently have do we need to get, and those kinds of things, and how often will we have to change them. Kind of in parallel with beginning the work toward decommissioning, as this group has probably talked about before, it is really useful to get anesthesiologists to cut their usage, both in terms of total liters of flow and minutes of just overall usage of nitrous oxide, so that it's not a real burden on the system to be changing out the portable tanks. And so I'm happy to, we've had some webinars with Epic, and there's an interest group forming from the informatics side, through them. But if anybody needs that information, I'm happy to get it to you.
Thank you. Anybody have any questions for Lucy or comments on that? Else we'll go to Antonia. You had a question.
Sure, thanks. And I stuck my quick question in the chat. It's fairly straightforward, but I'll go back to the more policy focused conversation, if you don't mind, Gwyneth, that Brian and Assis were talking about. So I think the question in my mind, and I think there's some appetite within HHS to maybe do this, is would a clarification letter coming out of HHS saying that there's nothing in NFPA 99 that should prevent the deactive NFPA 99/2012, as is in the current CMS conditions of participation, that would prevent the deactivation of centralized nitrous systems to go to, everybody. So it could go to departments of health, it could go to all their beneficiaries. Just a note to clarify that point. Would that be an accurate statement? It might need to be more detailed, though simplicity is always helpful, I think, if possible. Did that make sense?
It does to me, Antonia. I think it's a great idea. I think it's a strategy worth pursuing. Yes.
And Brian, would it be as simple as that, do you think? Oops, have we lost him?
Saying that there's nothing in 2012 that
there's nothing in the current NFPA 2012, which is the version CMS depends upon.
Yeah.
Yes, they should update it. That's another issue that we don't need to go into here. But there's nothing in there that should prevent hospitals from deactivating centralized nitrates. Is that a true statement? Is that something they could convey to give people that to ease people's regulatory anxiety to do this work?
Yeah, I would say that's a totally accurate statement. The difference between 2012 and 2024, I mean, the chapter and verse of the code is very similar in terms of how it's all laid out. Some of the verbiage is different, but the concepts are consistent that we refer to in our toolkit. So yeah, I think that's totally reasonable thing to do. I think having them say there's nothing to prevent you from doing it, and these are the principles. Should you decide to do it, these are the principles that you need to keep in mind as you go through it. It's mainly making sure that it's one of the main concerns about the deactivating of the central system that I've come across is that people are concerned that end users think that the system is active when it's not active. So that it's all about making sure that it's very clear that the system is not going to work. Like either you can't physically hook up to it, and that every point where there's a visual where you could visually see the system, it's crystal clear that system has been inactivated or discontinued or deactivated or whatever term you want to use. It's all about making sure that there's not an inadvertent connection back to the nitrous system by a clinician thinking that it's going to work and then it doesn't work. That's what they're really worried about.
Safety, the safety piece, of course, which is what it's all about. Yeah. Okay. So I just put that on the table. I think that's doable. I can't promise results, but I think it's certainly there's some openness to hearing the request.
Sure.
And Tony, this is Jeff. I'd make one more comment. There is also no requirement that you put a new piped nitrous oxide system in a new hospital or remodeled wing of a hospital. So in Providence, we've written in our technical standards, thou shalt not put piped nitrous oxide in hospitals or ASCs. And I think that's another point for everybody to consider. Making sure we educate.
And there's no regulation anxiety there. There's no I mean, you can do what you want. There's not like we must do it because those are the regs, right?
There is no requirement. There might be anxiety, but there's no requirement.
Yeah. And some people need to be informed of that. I mean, because our hospitals historically for the past, since hospitals were built, it seems like they've always been plumbed with central oxygen, air, vacuum, and nitrous. And so all of these people we're asking them to step away from a system that they've spent their entire careers tending. And it's hard for them to think that it's okay. But when you actually look at the FGI lines that kind of spell out what is required in new construction, in none of the FGI versions does it require centrally supplied nitrous.
So it's probably worth also noting, and it is not required. You can't,
Yeah.
I don't think they can encourage you to do something, but you can say what is not
Right.
required, certainly. Okay, in new buildings.
Hey,
And
Katie,
yeah,
sorry,
go
go
ahead.
ahead, Antonio.
Oh, I was just saying, Jeff, the point that you made on NFPA 99 being operating, not being designed versus operating, that's actually, I think, vital. So you can't just stick in that appendix, probably, right?
You'd have to change the wording to make the appendix part of the requirement. And it's a local jurisdiction or authority having jurisdiction that actually is the ones that enforce that requirement. So they adopt NFPA, and it's just a guideline until it's adopted by somebody with authority. And the document is not made for the appendix to be something that is essentially a regulation, a construction regulation.
I want to switch to Katie, who has her hand up, and then after that, go to Terry's question. So go ahead, Katie.
Thanks. I have one, and I put it in the chat, but I think another thing that might be helpful from whichever body would be best to clarify this, but is a nitrous oxide system actually a life safety system is an issue that I think that authorities having jurisdiction might have different opinions on, and therefore peg hospitals wanting to do this into some larger project submittal versus not. And wondering if we could consider asking, I don't know if it's HHS, but asking somebody to help us clarify whether or not nitrous systems and their deactivation and or whatever is actually part of the life safety requirements that would have to then be followed with like NFPA 101, for example.
So I think it gets grouped in because oxygen, vacuum, air, those are life safety systems. Nitrous is a drug delivery system. Nitrous is a drug. And as a clinician who has been trained to use nitrous, I can honestly tell you, I have never saved someone's life with nitrous oxide, right? It's a drug. And in the end, if they're really saying, well, you have to have access to this drug, this project is not removing access or eliminating access or restricting access. It's changing the way it's supplied. So that argument of saying, well, you can't eliminate this life safety system and restrict or eliminate access to nitrous, you could say, we're not. We're just changing the way it's supplied. And I think that argument often comes from really well-intentioned people who have grouped these systems, these central medical gas systems, together in their minds as being critical life safety systems without necessarily having a clinician's understanding of what nitrous is actually used for. It is not used to maintain anybody's life. It's used to administer anesthesia or analgesia.
Yeah, and I think that the just kind of answer that question. I don't think the rub is whether or not nitrous oxide will still be available. I think because it gets grouped into the other life, like oxygen and medical or vacuum and such like that, that then you have to follow the removal comments in the life safety like 101, right? To do a building alteration or something, which then might pigeonhole having to go through a big old plant submittal process. And maybe that's the experience in Washington or whatnot, but I feel like that's where we are running into some issues.
The other, if you don't want to take my opinion on it, which I would totally understand, the other group whose opinion you can provide as a counter argument to that is the FGI, who, if it were a critical life-saving system or life safety system or whatever the term is, then they would mandate that it be placed, but they don't, right? They mandate that every operating room has 2 oxygen outlets, an X number of vacuum, an X number of medical air. They specifically they're silent on nitrous. And when you read the editorial comments from FGI and those deliberations, the reason they say that is because they say the decision of the use and delivery of nitrous is a clinical decision left to the clinicians in your facility to determine. So don't take my opinion for it. It's totally consistent with FGI, which is setting the rules for all the states anyway.
And
I want to
Katie,
make sure oh, sorry, go ahead, Jeff.
I was just going to say to your point about code reference and authorities. I mean, I had a long conversation with the person who makes policy for the Department of Health and Construction Review in Washington, and I can tell you, they never considered that they would ever say, no, we couldn't do this. Their concerns were, we did this appropriately, we followed all the right steps, we did it thoroughly, and everybody up and down the chain from leadership to anesthesia to perioperative to facilities agreed with and knew what we were doing. They were looking at more as an oversight to make sure we did this appropriately and not whether or not we could do it. And I think that's an important differentiation. Never, ever was it, we're not going to let you do this. It was, we want you to show us that you understand how to do this safely.
Got it. Thank you.
I want to transition to Terry's question, and then I want to save a few minutes for us to discuss some next steps. So, Terry, do you want to go ahead with yours, or would you like me to read it?
Yeah, no, I can speak to it. Jeff, exactly to the point you were just making, that was with your examples in Washington. But how about California? How has HCI dealt with this matter? What's been your experience in California?
This is a little bit third party. I know the person that coordinated this with HCI, but I wasn't the person that coordinated it. Okay, Terry?
Yep.
And the person who coordinated it with HCI has a very good working relationship with the department and had a conversation with the department, described what we were intending to do in California, and was told that they would not consider that something they would have jurisdiction for, which honestly surprised us given our experiences. But I don't know that there was a formal written response. I think it was a conversation to the best of my knowledge.
So for us, of course, we have an inspector of record on staff or, with us, and they seemed to think that this was a no-brainer. So we were able to apply for this freer permit, which is just like a quick one. But the actual HCI officer pulled that back, and he said he wasn't in agreement that we could use the freer model to get this one approved, and that drawings would be required. So right now we're moving ahead because they're not responding. We're taking it upon ourselves just to keep moving, but it sure would be nice to have something in writing from one of our hospitals in California, from HCI, that says this is okay for hospitals to move ahead with.
And who does HCI report to? I mean, if somebody told them, don't worry about this, or are they, I don't know who HCI is, sorry.
HCI is the new OSHPD.
Okay, that
OSHPD, like it's a California specific agency that, that regulates healthcare facilities.
Okay.
And so all of those building codes and all of the national standards, and Jeff can speak way better to this than I can, only apply as much as HCI agrees with it, and HCI goes above and beyond. So
they're the final say.
California is held to all of their building renovations and permitting through HCI to get approved. So it's really slowed down our ability to convert nitrous. Not to belabor the point, but.
All right. We're close on time here, so I want to just spend a minute or two thinking about some next steps. I learned a lot in this conversation. Hopefully this was helpful for folks in terms of thinking about how to keep going or get started with this work. what I heard, correct me here, Antonia, is that we think there's an opportunity to potentially engage with CMS to potentially put out a statement, a clarification statement in terms of their position, and we will take some next steps in terms of developing that. Does that sound correct?
Yeah, folks are willing, like Brian and Katie and Jeff and John, of, what is it that we are asking them to clarify more specifically? We can, yes, absolutely. And Terry, it might have no impact for you, as far as I can tell, if California decides what it does on its own.
It would be
Go ahead,
nice. I mean,
Brian.
obviously the HCI person that you are encountering, Terry, is different than the one that Providence encountered. And this concept is new for all of these organizations, that it allows this inconsistent approach, so that it's not really HCI that's saying it, it's that representative of HCI is saying it. And it needs to be elevated above these kind of regional directors or whoever they are.
Yeah.
So that it's applied consistently across the state. We're not the only health system in California that has completed this work. There are lots of others who have done it, and have interfaced with HCI, through their own strategies. So it would be, and I think that's the power of a letter or a statement coming from CMS or HHS or the Joint Commissioner or whomever, to kind of set the tone and kind of provide some regulatory cover or consistency, so that people can refer back to it and say, oh, well, CMS is okay with it, or HHS is okay with it. HCI as an organization might change, but at least you could come back and challenge that regional director's perspective should he or she present an obstacle to you.
Can I make one point real quickly? Antonia, in the cms.gov Team Decarbonization and Resilience Initiative, there is a statement about decommissioning pipe nitrous oxide and substitute e-cylinders as an initiative of that program at CMS. So they're on record as saying they support this from that perspective. It's quite clear. I just read you verbatim what it said.
Yeah,
So
no,
maybe,
helpful.
yeah.
But
I
it's
think-
just a pilot program. I mean, it's relevant. I think we can point to it, but it'll probably have to go to a higher level, if you see what I'm saying.
And Antonia, you're on that policy metrics and financing work group, right?
Yep.
Yeah.
There are a lot of ideas here. We're at time, and I want to hand it over to Keith to wrap up, but I want to say that maybe we'll send out a poll after this, because there in the chat are coming up a lot of ideas for next steps and what might be helpful for folks. So we really want to find the most impactful ways to support this work. This has been very educational. And I think a next step will be following up. And we invite anybody who would like to participate in that process, and please give us advice, and reach out to us over email in terms of what some excellent next steps will be. Thank you guys very much for this excellent conversation. I'm going to hand it to Keith to wrap us up.